Welcome to Clinically Curious, where we fuel knowledge one concept at a time. In today's lesson, we'll explore cardiac rhythms, how the heart's electrical system works, how to identify normal and abnormal rhythms, and what they mean for patient care. By the end of this presentation, you'll understand the key differences between normal sinus rhythm and the most common dysrhythmias seen in clinical practice. Let's get started. The heartbeat begins with an electrical impulse, and understanding where that impulse starts and how it travels is the foundation of ECG interpretation. It all starts with the siotal node, or SA node, located in the right atrium. This is the heart's primary pacemaker, firing at a rate of about 60 to 100 beats per minute. When it functions normally, it sets the pace for the entire heart. Hence the name, the pacemaker of the heart. The impulse then travels to the atrioventricular node, or AV node, located between the atria and the ventricles. The AV node briefly delays conduction, giving the ventricles time to fill, and has its own intrinsic rate of 40 to 60 beats per minute. That means if the SA node fails, the AV node can take over as a secondary pacemaker. Next, the impulse moves down the bundle of His through the right and left bundle branches and into the Purkinje fibers, which then spreads the electrical signals throughout the ventricles. These ventricular pacemaker cells have the slowest intrinsic rate, about 20 to 40 beats per minute, and they serve as the heart's last backup system. This organized conduction sequence ensures that the atrial contraction first to fill the ventricles, followed by the coordinated ventricular contraction to pump blood throughout the body. This electrical harmony ensures each heartbeat is efficient, delivering oxygenated blood throughout the body. When this sequence is disrupted, though, arrhythmias and conduction blocks can occur, which we'll explore in upcoming slides. When the conduction system functions properly, we see what's called normal sinus rhythm. The heart rate is typically 60 to 100 beats per minute, with each beat initiated by the SA node. On the ECG, you'll notice a clear P wave before every QRS complex, a consistent PR interval, and a regular rhythm. The P wave represents atrial depolarization or contraction. The QRS complex represents ventricular depolarization or contraction, and the T wave reflects ventricular repolarization, or also known as refilling. Understanding normal sinus rhythm is essential. It forms the foundation for recognizing any abnormal rhythms. Students should take some time to memorize these normal parameters and practice reading ECG rhythm strips regularly. For additional practice, check the link on the last reference slide for an interactive ECG platform where you can test your skills and reinforce your learning in a hands-on way. Mastering normal sinus rhythm will make it much easier to identify subtle abnormalities when you encounter dysrhythmias in clinical practice. Let's examine sinus bradycardia and sinus tachycardia, both originating from the SA node, but with abnormal rates. Since sinus bradycardia occurs when the heart rate falls below 60 beats per minute, causes can range from normal physiological states, such as in a well-conditioned athlete or during sleep, to pathological conditions like hypothyroidism, increased vagal tone, or medications such as beta blockers or digoxin. Symptoms of bradycardia often appear when cardiac output is insufficient to meet the body's demands. These may include dizziness or lightheadedness, fatigue or weakness, shortness of breath, syncope or near syncope episodes, and in severe cases, hypotension or altered mental status. Treatment depends on severity. Asymptomatic bradycardia may not require intervention, but symptomatic patients may need atropine, temporary pacing, or even a permanent pacemaker. On the other hand, sinus tachycardia is a heart rate greater than 100 beats per minute. Common causes include fever, anxiety, hypovolemia, pain, hyperthyroidism, or a stimulant use like caffeine. Symptoms of sinus tachycardia arise from the high heart rate and reduced diastolic filling. Those symptoms may be palpitation and racing heartbeat, shortness of breath, dizziness or lightheadedness, and fatigue. Treatment focuses on addressing the underlying causes, such as fluids for hypovolemia, fever control, pain management, or beta blockers if the rate remains excessively high or the patient is symptomatic. By assessing both the rate and the patient's symptoms, you can determine whether intervention is needed or if it's a physiological adaptation. Atrial fibrillation, often called AFib, is the most common sustained cardiac arrhythmia you'll see in clinical practice. It occurs when hundreds of tiny chaotic electrical impulses fire throughout the atria, causing them to quiver rather than contract effectively. Because the atria are essentially fibrillating, there's no true P wave on the ECG. Instead, you'll see an irregular, wavy baseline fibrillatory activity, and the ventricular rhythm is irregularly irregular, meaning there's absolutely no consistent pattern between the R to R intervals. Atrial rate can exceed 350 beats per minute, while the ventricular response depends on how many impulses the AV node allows through. Some patients may have a controlled rate under 100 beats per minute, while others present with rapid ventricular response, or RVR, where the heart rate exceeds 100 beats per minute. Common causes of atrial fibrillation include hypertension, coronary artery disease, valvular disease, especially mitral disease, heart failure, thyroid disorders, lung disease, and post-cardiac surgery. It can also appear in otherwise healthy individuals, especially with stress, caffeine, alcohol, or stimulant use. Now let's connect this rhythm to what you'll actually see in your patients. Because the atria are not contracting properly, cardiac output decreases, and this can lead to palpitations or fluttering sensation in the chest, shortness of breath, especially on exertion, fatigue and weakness, dizziness or lightheadedness, chest discomfort or anxiety, and in some cases, signs of heart failure such as edema or dyspnea on exertion. One of the most serious complications of atrial fibrillation is thromboembolism, particularly stroke, due to the blood pooling and clot formation in the atria, especially the left atrial appendage. Treatment focuses on three key goals: rate control, using beta blockers, calcium channel blockers, or digoxin; rhythm control, through cardioversion or antiarrhythmic medications; anticoagulation to prevent stroke, guided by risk tools and risk factor scores. For persistent or recurrent AFib, catheter ablation or surgical maze procedures may be considered. Always remember, managing atrial fibrillation isn't just about restoring rhythm. It's about protecting your patient from complications and optimizing perfusion. So when you see this irregular rhythm with the absence of P waves, think AFib. And it says how it's affecting your patient both electrically and hemodynamically. Atrial flutter is another supraventricular rhythm that originates above the ventricles, usually from a single irritable focus in the atria, firing rapidly and repetitively. Instead of the normal sinus rate, the atria contracts at about 250 to 350 beats per minute, creating a fast but organized rhythm. On the ECG, Atrial flutter produces the classic sawtooth or picket fence pattern, a series of uniform back-to-back flutter waves best seen in the inferior leads, such as in lead 2, 3, and AVF. These flutter waves replace distinct P waves and give the rhythm a very recognizable appearance, almost like evenly spaced pickets on a fence. The ventricular response, meaning how many impulses actually make it through the AV node, can vary. You may see a 2-to-1, 3-to-1, or even a 4-to-1 conduction ratio, depending on how many of those rapid atrial impulses are allowed to pass through the ventricles. So in other words, you may see 2 P waves to 1 every QRS, or 3 P waves to every 1 QRS. This determines the patient's overall heart rate and stability. Common causes for atrial flutter include heart disease, post-cardiac surgery, pulmonary conditions like COPD, and hyperthyroidism. It can occur also transiently after cardioversion or in patients with structural heart changes. Symptoms may include, like I said earlier, palpitations, shortness of breath, dizziness, and fatigue. Treatments aim to control the ventricular rate using beta blockers or calcium channel blockers, restore sinus rhythm through cardioversion, and prevent reoccurrence of thromboembolism with anticoagulation therapy when indicated. Recognizing this distinct picket fence pattern on ECG is key. Once you see it, you'll never forget it. Now let's move on to 2 of the most serious and potentially fatal cardiac rhythms: ventricular tachycardia, also known as VTach, and ventricular fibrillation, also known as VFib. VTach occurs when the ventricles become the heart's dominant pacemaker. The ECG shows wide QRS complex at a rapid, often regular rate, typically over 100 beats per minute. VTach can present in 2 forms, with a pulse or pulseless. In VTach with a pulse, the heart is still generating some cardiac output. The patient may have a pulse, but they often appear unstable, showing signs such as hypotension, chest pain, shortness of breath, and altered mental status. Pulseless VTach, on the other hand, means there is no detectable pulse or effective cardiac output. This is treated as the same way ventricular fibrillation is, a full cardiac arrest requiring immediate defibrillation. So how do we know when to use the cables, meaning defibrillation or cardioversion? If the patient is unstable but has a pulse, meaning unstable, their blood pressure is low, they're hypotensive, we use synchronized cardioversion to restore rhythm while avoiding shocking during the vulnerable repolarization phase. If the patient has no pulse, that's pulseless VTach or VFib, and we move directly into defibrillation, the emergency shock that can restart the heart's normal electrical activity. VFib looks completely chaotic on the ECG, no organized QRS complex, just erratic and disorganized electrical activity. The ventricles are essentially quivering instead of contracting, resulting in zero cardiac output. Causes of both VTach and VFib include myocardial ischemia or infarction, myocardial myopathy, severe electrolyte imbalances like hypokalemia or hypomagnesium, and drug toxicity. Management depends on stability. Stable VTach may respond to antidysrhythmic drugs such as amiodarone or lidocaine. Unstable VTach with a pulse requires, again, synchronized cardioversion. Pulseless VTach or VFib demands immediate defibrillation and full advanced cardiac life support, including high-quality CPR and epinephrine administration per protocol. Always remember, rapid recognition and prompt intervention can make the difference between life and death in these rhythms. Now, heart blocks occur when there is a delay or complete interruption in the conduction of the electrical impulses from the atria to the ventricles. Understanding each degree of block and how it presents is crucial for early recognition and treatment. Let's start with the causes. Heart blocks can result from ischemic heart disease, electrolyte imbalances, aging of the conduction system, or medications such as beta blockers, calcium channel blockers, and digoxin. In first-degree heart block, every impulse from the atria still reaches the ventricles, but the conduction is slightly slower. On the ECG, you'll notice a prolonged PR interval greater than 0.20 seconds. Patients are usually asymptomatic, and this rhythm often just requires monitoring rather than treatment. In second-degree AV block, some impulses fail to reach the ventricles, meaning not every P wave is followed by a QRS complex. In Mobitz type 1 or Winky block, the PR interval gradually lengthens until a beat is dropped. It's usually benign and often transient. In Mobitz type 2, the PR interval remains constant, but occasionally a QRS complex are suddenly dropped without warning. This type is more serious and can progress to a complete heart block. Which brings us finally to third degree, or a complete heart block, in which the atria and the ventricles beat independently because no impulses are conducted through the AV node, meaning there's complete disassociation between the two. The atria follow the SA node's intrinsic rate, which, as you recall, we said was 60 to 100 beats per minute earlier, while the ventricles rely only on their slower escape rhythm, which is usually 20 to 40 beats per minute. Clinically, this is where you'll see significant symptoms due to poor cardiac output. Some symptoms you see is severe bradycardia, dizziness or syncope, chest pain or shortness of breath, hypotension and altered mental status, and extreme cases, loss of consciousness or cardiac arrest. Third-degree heart block is a medical emergency. Immediate treatment may include temporary transcutaneous pacing, atropine, if applicable, and preparation for a permanent pacemaker once stabilized. Let's review the key points from today's lesson, focusing on what you need to know for assessment, monitoring, and timely intervention. First, understand the normal conduction system and sinus rhythm. This is your foundation. Know the normal parameters, practice reading ECG strips, and recognize when something deviates from normal. Second, assess the patient, not just the monitor. Observe for signs and symptoms of abnormal rhythms: dizziness, fatigue, shortness of breath, palpitations, chest discomfort, hypotension, or altered mental status. These clues help you determine whether an arrhythmia is hemodynamically significant. Third, identify the rhythm on ECG. Be able to differentiate between atrial, conjunctional, and ventricular rhythms, as well as recognize conduction delays or blocks. Understanding the ECG patterns allows for rapid assessment and supports clinical decision-making. Fourth, prompt intervention matters. Symptomatic bradycardia or advanced heart block may require atropine or pacing. Unstable tachyarrhythmias like VTach with a pulse requires synchronized cardioversion, with pulseless VTach or VFib demands immediate defibrillation and CPR. Rate control, rhythm control, and anticoagulation are key in atrial fibrillation and Flutter. Finally, remember that early recognition, assessment, and timely interventions can save lives. Developing these skills now, practicing ECG interpretation, monitoring for subtle changes, and linking rhythm changes to patient symptoms prepares you for confident and competent clinical care. For additional practice, don't forget the link on the last reference slide to an interactive ECG platform. It's a great tool to reinforce your skills and connect theory with practice. For those who want to take their learning further, click the 3 links below to access additional resources, including the latest American Heart Association guidelines, some peer-reviewed literature from a cardiology journal, and an interactive cardiac rhythm simulator designed to help you practice ECG interpretation in a fun and an engaging way. Thank you for watching this episode and presentation of Clinically Curious. If you found this presentation helpful, please give it a like, share it with your classmates or colleagues, and subscribe to the channel for more clinically focused content. Together, we'll continue to fuel knowledge, one concept at a time. Until next time, stay curious, stay clinical, and keep learning.